sake of ये उठा के वहाँ पे the midfoot not showing any battery. आपको एक बार आँख खोलिए, एक बार बंद करिए, ठीक है? हम खड़े फिर करेंगे, ठीक है? चलिए पहले आँख खोलिए, बड़े सामने देखिए। Hello. There is no great toe is there, and the sway is basically on the right side. The patient is basically automatically putting a weight on the more hind foot rather than the forefoot. See exactly what happens when the patient while standing, it is the whole weight bearing on the right side. but now patient isn't dynamic, it's shifting the weight on the left side. So that shows this patient is cerebral bleed. So how dynamically he is changing is that. So how confident the patient is there until unless you don't fulfill the full rehabilitation, the clinical cues that somebody walks with him or either he will fall. Or so in a minute you can get the calculation of how much kilopascal pressure is basically is giving on the left side, is giving on the right side. The sway on the right side you know, but the weight bearing is on more on left side. These tools will give a real-time idea what you are exactly want to do with the patient. The problem is that the dynamic surface 50 साल 40 साल जो गांव का मरीज आता है 60 साल का मरीज आता है स्ट्रोक का वो कभी 50-60 साल डायनामिक सरफेस पे नहीं चला, कभी नहीं चला, और हम लोग उसको डायनामिक सरफेस पे चलाना चाहते हैं, वो भी इंसल्टेड ब्रेन के साथ. द आयरनी इज दैट without you don't know where exactly the foot pressure is coming, where the balance is there, where the sway is there. The exoskeleton, no doubt, that is bypassing all the things. It will help in the static surfaces. If you put the exoskeletal or robotics on the static surface, it definitely helps the patient, such patients. And if the patient who is having a power, but if patient don't have enough power, you want to make him a run or walk on the dynamic surface, it is not possible. क्योंकि अपने जीवन में कभी वो ट्रेडमिल पे नहीं चला है, गांव का मरीज 50-60 साल का, आप उसको इंसल्टेड ब्रेन के साथ वो करने को बोल रहे हैं जो उसने नॉर्मल ब्रेन के साथ कभी नहीं किया. उसका कोई मेमोरी नहीं है, उसकी कोई न्यूरल प्लास्टिसिटी नहीं है उसको लेके, उसके कोई न्यूरल कनेक्शन नहीं है उसको लेके, एंड यू डोंट हैव एन आइडिया आल्सो. So this tool, exactly before performing of any movement, you have an idea within a minute. See the basically how dynamically the things change. Now the foot centimeter area wise you see the left foot is basically having an 109. See that is an 100 and 148. How much dissociation in calculation is there? So it's a real time data you have. नीचे लेना बाहर जाके और and you can see the eye open and eye closed. You see the anterior weight distribution and everything you can calculate. So you can make it your basic homework. It is not for patient. It is always for the clinician who do the micro planning of walking or micro planning of rehabilitation before making a patient to walk. So the just having given an input how the tools are important nowadays and how it helps us to avoid certain mistakes which we are doing in ADL for in rehabilitation. And definitely ये सब चीजें समझना करना है, सारी चीजें नहीं possible है, but it's required a very less training. So Dr. Piyush has basically put a lot of effort to bring in those equipment. उनके स्टाफ के लिए ट्रेनिंग अरेंज किया, सब कुछ किया. Now they are doing an advancement. Same institution wise, this is the expensiest OPD department of physiotherapy in entire Rajasthan. The reason behind that, I want to objectify the physiotherapy. I don't want to do the subjectified. I don't believe in the scales. So we have numbers, certain numbers we can do pre, post, and we'll get an idea. So patient having a left side more weight bearing, then we have a close eye में patient का right side sway था, तब हमको ये पता है कि open eye में patient को right side weight bearing initiate करनी है और close eye में right vice versa करना है. Because cerebral bleed है, movement dissociation है, classical calculations है, everything is there. So thank you for patience listening, and I am just at home taking मेरा ये है, जब तक आपका फुट आपके ग्राउंड पे स्टे नहीं करेगा, आपका अपर लिम्ब का मूवमेंट अच्छे से नहीं परफॉर्म होगा, प्लीज आप लोग सब लोग समझें इस बात को, सीरियसली लें. और कोई भी थेरेपिस्ट ओपन चेन में रिहैबिलिटेशन कर रहा है लोअर लिम्ब को, वो गलती कर रहा है. अभी भी कह रहा हूं, अगर वो वॉक कराना चाहता है, पेशेंट इज इन बेड, जीरो पावर है, आईसीयू में है, यू डूइंग अ पैसिव मूवमेंट, दैट इज ओके. थैंक यू एवरीवन.
If there are any questions or comments before next lecture is set up?
Good morning again. So for this conference, we have some special guests all over from the Kerala. So firstly, I introduce to Dr. Jimshah sir. Even I am also taking classes from sir regularly, so I am a good fan of him. So Dr. Jimshah sir is a scientific assistant physiotherapy at the Department of Physical Medicine Rehabilitation, Government Medical College, Trivandrum, Kerala. His professional experience is he was working as an assistant professor, College of Physiotherapy, Dayanand Sagar University, Bangalore, Karnataka. Graduated from RGHS, Bangalore. He has a vast experience of 12 years post-MPT and is involved in various academic and clinical. He has conducted many workshops in the field of neurorehabilitation and advanced electrotherapy, which I am already a student, sir. And he was invited as a research speaker in various institutions, and he is also actively involved in various research works with a strict 22 publications in both national and international. So I invite sir for the presentation, and please listen this guy. This is really make your rehabilitation to a greater strength. Thank you.
For chairing a session, I will call Dr. Farooq sir or Dr. Hiredra Kataria साहब अगर हो तो यहाँ पे फारूक साहब प्लीज.
Good morning all. It's a great pleasure for me having here. So I'm going to discuss about some practical aspect regarding how we can treat a stroke patient in different stage wise. Okay, I hope this is going to be an eye opening for all. Okay, and understand one thing. So before starting, I would like to say this is not going to be a fully practical session because this is an elaborated version. I'm just going to give an overview. Okay, that means it's just an eye opening. So you need to understand exactly in different stage how to rehabilitate the patient. See, as you know, the importance of stroke and importance for a physio to rehabilitate and what is our role. Okay, it comes in a unique because it is one of the and our role comes in a very majorly patient. See, so before starting with my session, I was hearing that some session regarding neural plasticity. So the basic concept behind this technique. So whatever we are doing, either in the initial stage or in the in the mid stage or in the chronic stage, is basically we are dealing with the neural plasticity. So initially, the first initial hours, what initially immediately after the injury, the cells are trying to manage or trying to go for a secondary pathway. Later on, that changes into trying to make some new connection, and after few days or after few weeks, it changes into some adaptive mechanism. So I want to discuss something about neural plasticity, exactly how we are managing. The first point to remember, we need to prevent all sort of maladaptive plasticity. That means if you are not going to deal the patient properly, the cells or the upper extremity or lower extremity, there's a chance of going for some contractures, spasticity related deformities. So it is important for us to start from the beginning itself. That means from positioning, how you changing, how you are mobilizing the patient, how you are doing initial, acute rehab, how you are doing chronic rehab. It is very important for us to. Otherwise, there's a chance of adaptive plasticity. And the second important point in neural plasticity, we need to activate the silent synapses. That means in your brain there are two types of synapses. The one is functional synapse, the second one is structural synapse. Functional synapses are the synapses which you are utilizing in the functional way for different activity, cognition, memory, your motor activity, your sensory activity. They are the functionally activated synapses. But there are some structural synapses, but in chemical profile you are not changing and you are not activating into functional. So with your rehabilitation, you need to bring that structural synapse. That's second mechanism, the neural plasticity. Of course, the third one, collateral sprouting. That means the nearby area trying to take over the action. By activating the synapses and the nearby tracks and nearby areas challenging and taking over. Last one, regeneration. Is there any possibility for the injured neurons? Then is there any possibility to regenerate? So these are the main mechanism how you are practically activating in the nervous system. Now the important topics today. What is eclectic approach? My topic is regarding eclectic approach. So eclectic approach means you are trying to bring all the neuro rehabilitation concept together to get a better recovery. As we are learning so many techniques, starting from Bobath, NTT or roots, brainstorm technique, MRP, task specific. So each technique has got the positive and negative aspect. So it is important for you to realize when to use and what technique. For an example, at the initial stage, that means the stage of flaccidity, it is very difficult for you to use CIMT, constraint induced movement therapy, or it is very difficult for you to utilize MRP, motor relearning program, because to do those techniques you need to have some movement, but it's a concept. The same way, in the later stage, that means the patient once performed or activated some voluntary contraction, it is difficult for you to utilize some brainstorm technique or roots technique, because those techniques are good to use in the initial stage. So it is important for physios to realize when to use and what technique. That is what a single model or multi-model. That's the reason eclectic approach came, where you are bringing techniques and the principles from the different approach and you are bringing for the patient upliftment. That means how better way you can rehabilitate, how better way you can bring the patient movement. And it is more of individualized assessment. That means we can say it's a tailored. You can't use all the patient the same manner. For some patient you need to start with maybe initially roots technique, or some patient we can start with brainstorm technique. So it is an individualized rather than going the same manner. It is more of a tailored. For each patient you need to assess properly and you need to plan the treatment accordingly. For better understanding of this concept, brainstorm. The brainstorm, the author explained the rehabilitation for the stroke patient and explain different stage-wise sequence that you need to understand. The stage says that initially you have stage of flaccidity. That means no movement. Immediately after the stroke, the patient will go in a stage called stage of flaccidity. There is no movement. Then the second stage explained where slowly there is something called BLS, basic limb synergy develop. In the form of flexion synergy or in the form of extension synergy, slowly BLS form, same way we also start. This is what the second stage. And in the third stage, BLS has become marked. That means already your spasticity at the maximum peak. Then in next stage, slowly spasticity decline, that basic limb synergy break down and you start getting some independent movement. Then in the next stage, patient is getting almost a good movement before getting into a completely functional. So you need to understand this is a stage-wise sequence starting from 1 to 6, where the one showing the complete stage of flaccidity and going with slowly improving the tone, getting a BLS, the maximum BLS, where the maximum spasticity, then spasticity decreases, getting into an individualized. The last stage shows there are isolated joint movement. So every patient has to go in a different sequence. So to understand this eclectic concept, you need to see where each patient stands. You need to understand whether the patient is in the stage of 1, 2, 3 or whatever. So accordingly you can plan what treatment and what concept to give. And is a goal setting. So each patient you need to make a goal. It is in the form of SMART, where you have specific, measurable, achievable, relevant, and time bound. That means you need to keep a specific time for rehab. And of course, you need to understand one concept as we are dealing with a stroke rehab. It is time consuming. You need to accept that fact. We can't compare the same with other specialty. It is a time consuming, same way you are supposed to give enough space for the subject to practice. For understanding why? Because see, one command is very important. Okay, whatever technique you are giving, that loud command is very important. You should allow the patient to practice maximum, because practice and repetition is only one key point for the neural plasticity. Okay, it is a time consuming, you need to understand that. But keep it in your mind, you need to give a space. Space in the sense of at least when you are going to get an upper limb activity, okay, how many days you are going to try for it, and what are the techniques you are going to utilize. There, so after setting the goal, you need to go for an integration. That is what we are doing, integration. Integration means what? Bringing all the concept. For an example, initial stage, as I told you, stage of flaccidity, to get an upper limb activity, we can use a technique called as Brandstrom explained. There is something called as associated reactions. Okay, associated reaction and same reflexive technique. You heard about primitive reflexes, STNR, ATNR, TLRs. The same reflexes we can utilize in the form of initial stage, how to get some movement, which I'll show you some practical aspect. So, integration means you are bringing all the concept together, and how tailored way, how better way you can make each subject useful. See, it is a multi-modal. For an example, you can see the line. For an example, a treatment session for an acute upper limb. That means a stage of either flaccidity or changing into stage 2, slightly movement begins. You are supposed to use the technique is either sensory motor train, that's roots approach, Brandstrom technique, and Bobart technique. You got it? So initial stage, if you want to get some movement on the upper extremity, of course you are doing. So what usually we can say, first we start with passive therapy, then active assisted, then voluntary contraction, then bringing into functional. This is how usually we change each sequence. But we need to understand each stage, what technique and how it is useful. You got it? The initial stage for upper limb activity, you are supposed to use roots technique, Brandstrom technique, and Bobart concept to get an upper limb activity. This is for an example. Now what are the techniques? So I'll give you a brief introduction about each technique in eclectic. The first one says Bobart concept. So what Bobart concept says, before treating any subject, you need to understand what is the normal pattern of movement. This normal pattern of movement in the sense of, if you are trying to see, this I'm trying to move. See here I have so many muscle groups is working. Agonist, antagonist, fixator, synergist, they are working. But some are contracting, some are relaxing, some are assisting. You got it? This is getting affected because of stroke. Either the stage of hypotonia or hypertonia. Same way, you have a posture reaction. What is posture reaction? It is the ability of a person to maintain the posture whenever there is any push or pull. Correct? If I get any push, I am able to maintain, because this is a posture reaction. If it is too much push, I am putting step. This is getting affected. So normal pattern is changing, that you need to understand. Bobart says. Same way, you need to incorporate, affected side into the rehabilitation. This is very important. This is what the mainly we used to skip. For an example, how you are going to position the patient in the initial day one. It is very important. Usually, we get a patient maybe after a few days into the rehabilitation center or clinic, how ICU therapists are going to take care, or how the ward or the hospital physios are going to take it. It's very important, because the positioning itself is going to give a good impact later. So according to Bobart, you are supposed to position the patient towards affected side. You got it? Towards affected side, but how you are going to position it is very important. If the patient is completely medically stable, where they don't have any cardiopulmonary issues or orthopedic issues, if it's a completely stable patient, then better to position the patient in affected side, but make sure that you are supposed to position it properly. For example, for scapula should be in a protractor. So every time we get a doubt regarding if you position towards affected side, the patients are going to get a shoulder hand syndrome or subluxation. Why? Because you are not positioning it properly. To position towards affected side, make sure that after turning towards affected side, you should bring your scapula into protraction. Then the patient is completely giving weight bearing on the scapula, not on the shoulder. You got it? So same way, I'm just giving important. See, positioning itself is an impact for a patient. Same way, how you are going to transfer the patient. Usually one side is affected, it is easy for the subject to get up with the normal side and sit. But do you know what we discussed initially? Neural plasticity. The brain gets adapt saying that, see, the subject is able to do a sit to stand in a normal pattern with the unaffected side. Again, problem. The patients are going to ignore the affected side. So make sure that if you are going to transfer the patient, it should be towards affected side. That's what Bobbard says. You have to give importance to the affected side in the rehabilitation. Now, the second one, brainstorm technique or brainstorm approach. What brainstorm approach says importantly, at the initial stage, if you don't have any movement, utilize the movement by using reflexes, primitive reflexes. For example, ATN, asymmetric tonic neck reflex, symmetric tonic neck reflex, tonic labyrinthine reflex, and tonic lumbar reflex. So initially try to use some reflex, you may get some response. Or you can use associated reaction. What do you mean by associated reaction? Try to move unaffected side. Give resistance to the unaffected side, you may get some response on the affected side. Suppose right side is affected one, give some resistance on the left side, a specific pattern is there. Left side, you are going to get some response on the affected side. This is what, associated reaction. And Root says you should go in a sensory motor approach. That means go with facilitation inhibition technique. So Root says facilitation inhibition technique. Example like fast brushing, quick icing. So these are the activity which you can enhance the neural output. So initial stage, go with some form of facilitation technique to integrate and to get some movement. So Root's approach. CAMT, as I told you, constraint induced movement therapy says this is specifically for the affected side hand. So here what you will do, you are going to constrain the unaffected side. Suppose right side is affected, left side you are going to put it on the sling. You are not allowing any movements to happen on the normal side. And the patient has to use, trying to get activated by using the affected hand. This principle is called as learned non-use. You know what happens? After the stroke, the patient is trying to get the movement, but not happening. This leads to a sequence called as learned non-use, saying that I learned this is not useful. From the principle start here, Edward Top, who is a psychologist, who is a pioneer of the CMT, what he says, you should start with constraining the, your unaffected side. This side not allowing to move. You have to put it on a sling and ask the patient to try to utilize the affected side. This is what CMT. But this you can use only in the later stage, not in the initial stage. A MRP, what is motor relearning program? Karen Shepherd technique says you need to understand the movement first and see how each movements are occurring. You need to break it and practice it. This is what MRP, motor relearning program. First analyze the movement, see what movements are missing. For an example, for reaching or for a glass of water, first ask the patient to perform that movement with the unaffected side. The patient is seeing. Then ask the patient to do it with the affected side. The patients are trying to understand what are the missing movements. You are giving proper explanation and trying for each joint movement. This is what MRP. And last one, FES, functional electrical stimulation is one of the important rehabilitation where simultaneous stimulation of electrodes will help you to get a contraction in the form of function. FES is used for sit to stand activity, walking activity. So it is more of how you are bringing all the techniques together and how you can activate it in a better way. And task specific. So most of the time what neural plasticity says, instead of doing a normal repetition, make sure that task specific, give a task. So when you see a task, the patient is able to see a visual stimulation, you are giving a proper auditory stimulation by using a command and ask for the repetition. And it is more of, it is not a single team or it's a teamwork. Always you need to understand it's a teamwork, it's a rehabilitation where there are a lot of rehab professionals are involved to get a maximum potential recovery for each subject. That is very important concept for you to realize. So we have to think about more about our role in the form of mobility and physical part, but there are some other areas is very important for you to read. And you need to give proper education to the patient and the bystanders for the maximum repetition. See, most of the time you are going to see a patient, you are going to give an input, you are trying to activate some movement, and remaining time if the patients are not producing any movement or the bystanders or relatives are not involved, you are not going to get a complete potential recovery. So make sure that you are giving a proper education about to the society in the sense of the relatives or the staff, then you are going to get a potential recovery. And clinical decision making is one of the important point in this. As I told you initially, you need to see each patient, individualized assessment, and you need to plan accordingly what type of treatment, what type of technique to apply. One technique you try, if it is not happening, you go for next technique. How potentially you can activate to get a movement. So what are the core practical areas to remember? As I told you, positioning. It's very important. Positioning, you are going to use more of Bobath concept. Line to sitting, again you are going to use key points. Bobath says there is something called as a key points of control. If you want to get an upper limb activity, your key points are scapula and wrist joint. Same way, if you want to activate your tongal activity, your key points are central key points, where in the anteriorly xiphoid process, posteriorly T7 vertebra. Same way, the lower extremity, if you want to activate key points, your key points are pelvis and the foot. So these key points you need to activate to get a better activity. Same way, line to sitting, as I told, transfer towards the affected side. Keep it in your mind. So most of the time we are going to do towards the unaffected side. It's easiest way, because the side is normal, it's easy for the subject to get that. So make sure that you are supposed to train and give a chance for the subject to utilize the unaffected side first. It is a difficult task, but there are easiest way how Bobath explains. And sit to stand activity, the better sit to stand activity you can train by using MRP, motor relearning program. And walking also you need to see by using MRP technique. Each stage wise you need to understand and give the task. Same way, upper limb activity. So it is as I told you, this is going to be an elaborated version where we are going to demonstrate each technique tomorrow. Okay, I'm just giving an overview today. What all techniques to use and how to use it. This is already I told you. Positioning, what technique to use. Line to sitting, what technique to use. Transfer, there's three types of transfer. The maximal transfer, moderate transfer, and the minimal transfer. In the sense of where you are going to utilize all the key points under your control, and transferring is the maximal transfer. And the moderate is where the patients are getting some control, you are leaving some key points. So how you are controlling all the key points, and transferring is a maximal, and when you are not controlling, it becomes minimal. So what is the evidence base? This is not my word. This already studies have proved. So in the evidence says, in the stage 1, 2, 3 for brainstorm, the techniques are good with reflex, basically your roots technique and the brainstorm. As I told you already, the initial stage where you don't have any movement, so better to go with roots and the brainstorm technique. But the later stage, go with task specific, your Bobath, and your MRP, CMT, you can go the later stage. So stage wise, if you see brainstorm technique, according to the brainstorm stage, initially go with roots technique and Bobath technique and brainstorm technique. The later stage, You can go with the all other task specific, MRP, CMT, because all the movements are happening. This is how the international studies, their findings says each stage what technique and how to activate. Right. Now I'll show you some videos how we started and how we utilize some techniques in the initial phase.
अमेरिकन हॉस्पिटल
So in this patient,
नाम तो पूछो बताओ बहुत ज़्यादा अर्जेंट से ना
so here I am going to show you how initial patient, that means in the state of acute phase, how we utilize Brainstorm ATNR technique. Okay, here you need to understand how the positioning and I'll explain each one. See now, okay. So here the position is for the ATNR, asymmetric tonic neck reflex. So what this reflex says, if you see, you can look at me. This is what the reflex. If you turn your neck, that means if you rotate your neck towards any direction. Okay. If I rotate towards right side, what is the reflex here? The side which I am rotating, I am going to get an extension response, and the opposite I am going to get a flexion response. You got it? If I am rotate to the right side, I am going to get an extension response here. This side, flexion response. If I rotate towards left side, same way. Here extension, here flexion. Now, what Brainstorm says, try to activate, utilize this technique. You may get the response. So here in this patient, see, we are rotating towards right side and we are trying to get the extension response. Okay, this patient was not getting. See, when the patient is rotating to the other direction, patient is getting flexion response. Same ATNR principle you are using. This is about the ATNR, how asymmetric tonic neck reflex is activating. But other hand is called reinforcement. The Brainstorm is explaining some other principle also. When you are not able to elicit any movement, ask the patient to use maximum reinforcement on the normal side. So here heavy contraction, heavy resisted exercise on the unaffected side, again you can elicit some movements. Got it? I'll show you one more. This is again the feature called, or the sequence called abduction response. The response name is Ray's phenomena. Ray's phenomena. Here, here what is the response? See, suppose understand. Okay, I'll try to show you in practical here. I just want one more. So here I am trying to show you how initially we can facilitate the lower limb. Okay. Here I am going to use a technique called Ray's phenomena. So what this phenomena says, you have two types. One is abduction response and other one adduction response. Okay. So what is the first one? You need to try for the adduction response. So what it is, give resistance to the unaffected side adduction. You need to understand. Suppose left side, in this patient, this subject, left side is affected, and this technique you are going to utilize in the initial phase. So here my role is, what I have to do, keep it in little abduction position, unaffected side. Understand? Unaffected side, both. And ask the subject to do resistance adduction. Adduction resistance, and your command should be, bring both the legs together. You are not supposed to say, try for the movement. Just give a command saying that bring both the legs together. You got it? So what here I am going to do? I am going to resist the movement on the unaffected side. Okay? Now try to bring together. See, this is what the response. This is called adduction response by Rayleigh's phenomena, and the author is Brainstorm. The same way, the first you should try for the adduction, the second you should try for the abduction. To do abduction, you see, same way, you have to keep it in the adducted position and ask the patient to bring it apart. You got it? Again, you are doing in a functional way. You are not supposed to ask the patient to go for a movement. Okay? So this is what abduction and adduction response. When you don't have any movement in the initial phase, you can utilize this technique. But the problem of these techniques, when the patient start getting movement, immediately you should stop. When the patient shows some voluntary response, you are not supposed to continue with this reflexive technique. Otherwise, there's a sequence called as reflex binding response. That means whenever patient is doing this technique, then only patients are going to respond. So you should not. This you just utilize in the form of initial facilitation. When patient shows voluntary activity, stop your facilitation, ask the patient to repeat for the voluntary movement. Fine. Now I'll show you how ATNR is activated. See, all of you try to see the movement. See, what is ATNR says? See, whenever you rotate towards any direction, the direction where you're rotating is, you will have an extension response, and other side you will have a flexion response. This is what the reflex. Now what you will do, ask the patient, suppose left side came in, so what you will do, ask the patient rotate this side and keep it in slightly externally rotated, and what you have to do, you have here skewing. Skewing is a technique from Brainstorm. So you are trying to skew the integration I am doing. Why integration? Skewing and tapping is from Roots approach. Same way, this technique is from Brainstorm approach. So, I am trying to utilize all the techniques together to get a maximum potential result. So, turning and ask the patient to look, and same way, try to activate. If it is an ATN and sustain, you can get some movement. If you want to go for a flexion movement, biceps, what I will do, ask the patient to rotate other side, here I will do tapping. Tapping is technique from Roots. So, whenever you tap, you are activating your muscle spindle activity. It's a form of technique, you are activating your receptors. So, two things I am doing. One is positioning, externally rotated, then ask the patient to turn towards the abducted side, and activating triceps and skewing I am doing. Same way, rotating opposite side and flexion, that thing I am doing. See, two things at the same time. And this can go in a different level. What is the first level? Just observe the movement. Is there any movement? After positioning, ask the patient to try for the movement. First observation. In observation you found this is not happening, then what you can do? Just activate ATNR. Second thing, activation of ATNR. Here there is a third thing also. What you will do? Reinforcement. What is reinforcement? You bring the relatives and ask them to hold properly here. This you can practice it very well. When the patient is trying to hold tight, and here the tone you can see improving. And the last one, heavy resisted exercise. What you will do? Here you will give 2 kg or 3 kg weight cuff and ask the patient to try for some movement. That contraction also you can see on the upper side. You see, you are going a different stage wise. These are two techniques which I am practically showing, but you have a lot of other techniques which you have to practice in the initial stage and the later stage from different concepts which we are going to demonstrate tomorrow. Okay? So any doubt regarding the session? So ultimately I want to tell you, see, this should be your task. This is what your task should be. First, select the subject. Of course, you need to select the subject depending upon what condition, the area of involvement. Sometimes the upper limbs are involved more or lower limbs are involved. Depending upon that, you select and select the approach. Very important. As I told you, you are not supposed to go with, okay, he told that initially go with only roots. No. Select the subject, select the approach, which one is appropriate. Then initiate or control the movement, trying to activate. try to activate some voluntary contraction, then go for maximum repetition with that contraction. Mass practice. See, most of the approach say mass practice. Why mass practice? You practice more, learn more. That will help you to get your neural plasticity, new connections. That's the reason robotic therapy explained the maximum repetition. Maximum repetition will help you to get a better learning. Better learning will help you to get a better neural plasticity. So mass practice, give enough time and space. Isolate. Finally, what you want, your last stage of brainstorm, isolated movement. So you need to go each stage wise to achieve this, but in each stage, what techniques to use, when to use, that is very important. Right? So thank you.
Very nice talk. Really very nice. So you have strength left, or we can do one more talk, then we can have a tea break if that is okay. Sir, आप तो अभी आए हैं. So anyway, so we'll continue with this another talk. I just wanted to ask you, is it this CIMT constraint? It's same like roots approach, Bernstein approach, and CIMT. I mean, how do they differ? I mean, from clinical perspective, would you guys?
See, CMT is a technique used for, specifically at the later stage, and this technique is used only for the hand function. Most of the time we get a doubt, CMT is for entire, body or not. This technique is only for hand function. See, only hand function. So what they say, to do this technique, the patient should have some qualifiers. That means the patient shoulder movement should be, there are some range, elbow movements, even hand movements, hand function should be not completely normal. At least your MCP and IP should have some 5 to 10 degrees of movement. And this technique is what? You are trying to stop the movement on the unaffected side. Here what you will do, so we have video presentation for regarding that. So what you will do, here this hand you will put it on a sling. This is normal side. Normal side I put it on a sling, and remaining time ask the patient to go with maximum repetition and the mass practice with the affected. This is what CAMT. Now what is roots? Roots concept is mainly for pediatrics actually. This roots concept mainly for pediatrics because roots says the child should go in a different stage wise. There is something called as mobility stage and stability stage. For an example, mobility, first always we see whether neck control is achieved or not. Neck control achieved, rollover effect is there, pivot prone, the child is able to, prone on elbow, prone on hand, and quadripod position sitting. So this is what the mobility and stability stage by roots, and you need to utilize the facilitation and inhibition technique. So facilitation techniques are the techniques how you can improve the neural firing, and inhibition techniques are the techniques how you can reduce the neural firing. So this is basically sensory motor techniques to get a normal pattern of movement. That's what roots. But CMT is completely, you are stopping the movement and you are trying to activate the movement from the upper face. Right?
Thank you, Dr. Jimshah, for a very wonderful insight about the all techniques. This is very useful in the neurorehabilitation. So from all the way you come here and teach us and our students, thank you so much. And I'll call Dr. Piyush Devpura Saab for the introduction of next faculty.
So now I invite Dr. Subin Solomon sir. We already know him, and in physiotherapy we are reading his book. So I just introduce sir. He's now workplace is CRT Department of PMI Government Medical College, Kottayam. He was Professor Department of Physiotherapy, EMS Memory College, Cooperative Hospital Research Center, Perithalam, affiliated to Kerala University of Health Science, Kerala. Early to that, he was a professor in the Padma Shri Institute of Physiotherapy, Bangalore, affiliated to Raghus, Karnataka. He received the BPT degree from Padma Shri Institute of Physiotherapy, MPT from Manipal. He is a resource person for the state, national and international conferences. Subin sir was conferred with the Academic Excellence Award KAPC 2017 Best Physiotherapist Award in South Indian, IIP Tamil Nadu in 2017, Excellence Award in 2018, National Award in 2019, titled as Young Achievement Award from IIP 57th National Conference held in Bangalore, Best Author Award in 2019, Innovative Award in 2022, and Significant Achievement Award 2023. He has done 46 publications in international journals and authored book titled like Biophysics, Therapeutic Electricity, Vascular Rehabilitation, Techniques in Cardiopulmonary Physiotherapy. And he has, being a teacher, he has done so many researches.
हमारे सामने पड़े थे और आज वो खाना आएगा स्ट्रोक ऐसा बोल रहा वीकनेस जैसे बता रहा था हो सकता है बाकी ग्लियोमा वाला भी आएगा पहले भी उसको
So good morning, one and all.
आपने देखा था उसने बताया था
Session in this chair, I would request to Dr. Antri sir, please come, and Saxena sir is there. So please.
So good morning, one and all. So my session is on like the most difficult problem in the stroke treatment is getting the finger extension and dorsiflexion. So I have some videos also for that. So before starting, I presently practices only treating the brachioplexus injury patients and stroke. We have around 14 districts in Kerala. I have all patients from all districts of Kerala. They come to me for the special treatment. So I just introduce with that one point of brachioplexus part to show you how it actually is neuroplastic. So you know in brachioplexus injury all the nerves are cut. So now the one surgery has found, new surgery has come, that's called as nerve transfer. So this patient has paralyzed the right hand. So the surgeon has transferred the opposite side nerve from the left side to the right side. So you know the left hand controls by the right brain and right hand controls the left brain. So now with this surgery, the opposite nerve is transferred to the paralyzed side. Okay. So with neuroplasticity, with repetition and practice, patient is able to move his right hand by the right brain. Normally, your right hand is controlled by left side and left side is controlled by right brain. But with this protocol, we are able to move the paralyzed hand by the movement of left side. So left side nerve is transferred to the right side. So moment he try to do any left side movement, you get the movement in the right side. So this is after 2 years, and after 5 years now he is able to do it independently, the elbow flexion extension. So neuroplasticity works with practice and repetition. So for that I am just showing this video. So this is a pan brachioplexus injury full avulsion in right side. Now with neuroplasticity we can produce movement in the right side itself. So that surgical procedure is called as nerve transfer, and the new physiotherapy protocol is called as DAFRA. I have modified this DAFRA in a WSBT conference. I have presented it. So this really works on the patient. So in studies it shows 8 years it takes minimum to get movement, but with my innovation we get the movement within 2 years. You can see here another brachioplexus injury. So his right side is paralyzed, so the nerve is transferred from the left side to the right side. Can you see when the moment he do movement in the left side, the right side is also moving? Can you see that? So this is after 3 years of surgery. Now at present he can do independently without any movement in the left side. So what I am emphasizing is your right hand is always controlled by left brain and left hand is controlled by right brain. But neuroplasticity, we are moving his right hand with the right brain itself. We have created a new center in the brain with your neuroplasticity. Neuroplasticity means practice and repetition. This case, the phrenic nerve is transferred to radial nerve. The moment he breathes, he get the elbow extension. This is after 1 year surgery. At present, he can do 2 kg, he can lift it and move. So this also, phrenic nerve nucleus is different and your right radial nerve triceps area is different. So we recreate it with practice and repetition. Okay. So we'll start off with our topic, how to move a paralyzed hand. Okay, so the most difficult problem in the stroke patient is to get the finger extension and the dorsiflexion of the ankle. So I'll just teach you one technique today. Detailed will be taught tomorrow. So 1 or 2 techniques I'll be showing today. So I combine roots approach, Brandstrom approach, Bobath approach together to get the movement. Okay. If you want to get a finger flexion, I use STNR, I use ATNR, I use pistol grip, I use tapping. Tapping is used from the roots approach. I use reinforcement. I use tapping with ATNR. I use imitation sequence. If your right side is paralyzed, you use your left hand. You try to squeeze it a ball. You all give the medicine, the yellow ball you give for the right side, but you should give it in the normal side and ask him to squeeze, and you get movement in the right side. So this is a case where fresh case of intracranial bleed. So this was the status of his hand. Now with this technique, what I have used is, you can see the patient, the bystander. Patient is holding the bystander hand. You need to give a pistol grip. So once you give pistol grip, ask the patient to look at the hand. So when you flex your neck, what happens is, in upper limb you get flexion, lower limb you get extension. So that reflex is called as STNR. So use that, you can see immediately you can get the finger flexion. Okay. So I'll be demonstrating at the end of the session. Now for finger extension, again you have pistol grip, Stokes phenomena, central key point, shaking, proximal key point, RIP, distal key point, etc. So you can see here a patient, 2-year-old, he is having a spastic hand. Okay. Now you can see how his hand is fully flexed. Now what intervention we give here? So first of all, the first thing you should do is a spastic hand. Always you should take into abduction with external rotation. That is called as the proximal key point, which is I have adopted from Boba. The next thing you should do is thumb abduction and wrist extension. So once you do that and you hold it, so this is a thing I am doing for him. So I just do it for around 20 to 30 seconds. Now you can see the effect. So I'm giving tapping on the extensor side. You can see the flexion is happening. Okay. So here at least 7 things together if you do. If this patient, I got immediate response. After 2 years, I am seeing him. On the day itself, I was able to get the finger extension. This patient is again a 2-year-old patient. When he came to me, the hand was like this. So I gave immediately this treatment technique. It worked out. He was able to get finger extension. So detailed procedure, I'll show it. And I am doing here abduction, external rotation, thumb abduction, finger extension. Hold it for 30 seconds. Okay. Then you take the pistol grip. So this is called as the pistol grip. Why pistol grip is whenever you put thumb in abduction, Bobat says that the hand spasticity goes. So now you can see how the finger is extending. You can see in the opposite side also the patient is doing finger extension. That is the principle adopted from Brunstrom, imitation synkinesis. So you can see the response. Did you see that? The index finger and the little finger was able to move. Now I want to show you the technique of dorsiflexion of angle. So these many things together if you give, many of us do only one of this technique. But if you try to give this all technique together, immediately you get the dorsiflexion. So first thing you should do is a principle adopt from the BNF, that is irradiation. So what is irradiation is if you have a stronger component, you strengthen that, the weaker component will move. Okay, always for the position to get the dorsiflexion is if you put hip and knee flexion, as per Brunstrom, you get dorsiflexion. Okay, then you hold the medial malleolus and the lateral malleolus and press downwards. So as per rules, if you give compression to a joint, you get extensor tone. If you give traction, you get a flexor tone. So your aim here to get the dorsiflexion, which comes under extensor synergy. So if you want to get dorsiflexion, you hold medial malleolus and lateral malleolus, press against the floor. Then Bobat's principle says bang the heel. You bang the heel, you get dorsiflexion. Then Bobat says stroke the lateral foretoes except the great toe. That also will give dorsiflexion. Then I touch the skin of the above the dorsiflexor with my forearm. That also will improve the dorsiflexion. So I'll just show that video here. So this is a patient where he doesn't have dorsiflexion for 2 years. So first thing I am doing here, resisting the hip flexion. So first thing you should do that, resist the hip flexion. After that you take the leg out, put in hip and knee flexion, hold the medial malleolus, lateral malleolus, bang it, then stroke the lateral foretoes, you get dorsiflexion. Okay. So these are the things together if you give, you get dorsiflexion. So now I will demonstrate all these techniques. So same time you can watch the video, same time you watch the model. First thing, any patients if you don't have dorsiflexion, but the criteria for getting this is at least hip flexion should be there. If the patient is having hip flexion, you just put the leg outside like this, okay, then you resist the hip flexion. I will resist it. Just try to do 3 to 4 attempts. Okay. After that, hold the medial malleolus and lateral malleolus, bang the heel. Same time, touch the skin of above the dorsiflexor with my forearm. Bang the heel, stroke lateral foretoes. You get the dorsiflexor. Okay. So you can watch out here. First resist the hip flexion, combine hip and knee flexion, bang the heel, laterally stroke the foretoes except the great toe, compress medial malleolus and lateral malleolus, and put the skin, you put the pressure over the skin above the dorsiflexor. Okay, ask for the voluntary comment.
What was the original, problem was nerve problem or stroke?
Stroke, sir. But I am saying after 2 years. The next, I will show how to.
My question is, if the patient has spasticity, obviously he has a tonus.
Extreme spasticity is not possible.
No. Tonus can be ill sustained, it can be sustained. So, suppose he's got a grade 2 spasticity. He still has spasticity. He still has, if you tap the finger, all the 4, he's going to get the dose.
Yes, sir.
So that's a normal phenomenon which happens because of spasticity. Yes, so how you say that what I have induced has caused the
we have to integrate, sir. As per Brunstrom, that's what the Bobat says that this is a natural phenomenon, don't use it. That's what Bobat says. So what I am telling you, try to take all this response together and you do for 3 to 4 days. If you do that, then next week you can withdraw all this, patient will get movement independently. So this is the sequence, and you train it for 4 to 5 days, then withdraw all the reflexes. stop all this reflex and try to do individual. Use that. Just come. Now I'll just show you if in the case of extreme spasticity, how to get finger extension. So first of all, ask the patient to hold the bystander's hand. If the patient is having extreme spasticity, first you need to do shaking. So shaking is a technique adapted from Bober. So do a shaking, it will withdraw immediately the spasticity of the hand. Because we are going to elicit finger extension. So before that, you should reduce the spasticity in upper lip. So just give shaking, okay? Then hold the bystander's hand. Now you take into shoulder abduction and extension. As per Bober, this is called as proximal key point. So in proximal key point, abduction and external rotation if you take, don't touch the spastic hand, touch only the tip of fingers. Now you have to put it in abduction. Fingers should be in extension. If you hold like that, that will reduce the spasticity of hand. Hold it for some time. Then come for a pistol grip. This is how you do a pistol grip. Then ask him to do flexion. Now while extending, you can just tap. Play the video. So to get the finger extension, you should give extreme spasticity. First, you should reduce spasticity. That is why this principle, the reflex inhibiting posture, the key point should be used. Shaking also should be used. So now go for pistol grip. Now you can see the finger goes into extension. This is only the first attempt. We did it for 3 days, and after 5 days, he was able to get full extension. The next, another technique to show finger flexion. So for finger flexion, hold the wrist in minimal flexion with a pistol grip like this. Hold the bystander's hand, tap it here. Come on. This is STNR. What is STNR? Symmetric tonic neck reflex is when you do neck flexion, you get upper limb tone is increased, lower limb, upper limb you get flexor tone, lower limb you get extensor tone. So ask him to look up. That time, same time, roots approach, you tap here, you get finger flexion. So this is some of the techniques I showed you. Some more techniques will be shown tomorrow. So any doubts? Any doubts?
I have a lot of questions.
Yes, sir.
Tell me what grade of MAS you are going to do.
I should modify the scale.
Obviously, spasticity is always good
Yes.
at MAS.
So motor assessment scale is also that's why I asked.
No, the spasticity is only assessed by MAS World War.
You can do anything below. If the clonus is not there, you can do it.
You said extreme spasticity.
Extreme
no,
means,
there is no mild
yes.
further extreme.
I showed
Give me
you.
the grade of spasticity. What do you mean by extreme?
Extreme means it's like totally tight, where
So what
isolated triceps movement is not there.
If you have a spasticity in the hand with a stroke patient, if you look at the stroke patient, there are various kinds of hand deformity. Thumb in hand, or the finger flexion, or the flexor spasm of the flexor rotation of the hand, wrist, or elbow flexion, and the pronation. So, when you have extreme spasticity, we are talking of mass scale of grade 4. Please understand that internationally, if you have to define the spasticity today, it is the MAS. You cannot go beyond that. You have to do that. Then if you write a paper, it will be only accepted if it is followed the MAS. So when you talk of extreme is MS4.
We can
MAS4, you cannot even open the finger of the patient. Alright?
Yes.
So what you are showing here is grade 2 spasticity on MAS. Now, if a patient has got a spasticity, you tap it on the wrist or elbow, anyway he has got finger flexion. This, even if a cervical cord lesion, there is a, you tap on the hand, you get a finger flexion. Because that is a part of the reflex.
So in that case,
So
we-
how you are converting that? My question is, what you are showing is fine. How you convert it into the activity of the patient? Is it feasible that with your this treatment, patient motor power from 0 come down to 1 or 2? That's what I am wondering.
Yes, sir. Come, sir.
I really want to see those patients.
Yes, I'll send, sir. I'll send.
Yeah.
I think, sir, means with repetition of these movements, if they are
I
repetitive,
give,
intensive, you may have improvement in power later.
Yes, sir, I tell the patient to do roots approach 4 hours.
My dear friend, I have been using botulinum toxin for spasticity for last 30 years, more than that. And I know which cases I have been using, right from grade 2 to grade 4. I know exactly that no movement, because they are so painful, patient don't even allow you to touch his hand many times. You are not talking of a spasticity after 1 month or 2 months. You are telling me all patient after 2 years.
Yes, sir.
It's very serious status of the patient. And if in 2 years, if you can show me with this tapping, patient improve in motor power, I really want to learn from you.
I'll send you the video. I have present status also. I'll send you. I have the phone numbers. I'll send you. So adding to sir's point, if you want to get the finger extension, first finger flexion should be there, and before that I will try to get the elbow extension first. So as the hours are limited, I didn't show it. I have videos of how to get elbow extension in a spastic patient. If time permit, let me see whether I can show now. So this case, extreme spastic of biceps. So we did around 10 days for him to get a triceps movement. So the moment he rotates to the head to the opposite side, he's getting biceps. So that is ATNR. I use here reverse ATNR. So sir, now reverse ATNR. I am getting the extension. So I train it, and after 1 month we isolate this reflexor. So that's a brainstorm concept, is use the reflex to facilitate movement. Once you get the movement, you withdraw the reflex. So like this, first I will get the triceps movement, then I try finger flexion, then the last only I will try finger extension. So for criteria for getting finger extension or to train finger extension, you need to get some movement in the triceps. So here in this patient, we are using brainstorm approach, the reverse ATNR to facilitate. And after 1 month, he is getting, you can see the moment the head is rotating to opposite side, you get biceps movement. And the moment he rotates to the same side, you get the tricep movement. Now, so here this video, what we shown previously, initial part of this video is showing the reflex, but the second part, from here onwards, without reflex, the patient is able to get the elbow movement. Can you see that? So in the same video, in the same time, the first 10-second patient was using neck movement to get the triceps, but from the second part, you can see without any head rotation, you are getting the triceps movement. So as soon as you withdraw the reflex, you get the response. Okay? Any other doubts?
session of techniques and very useful discussion. I mean, sir was telling that these are reflex movements. Probably if they are repetitive, if they are intense, it might help because it's very difficult to get, a useful movements with spasticity after a couple of years. Anyway, thank you very much. Very nice presentation. And before, I know you must be very exhausted. We'll go break. Before we break for tea, I would request Professor T.C. Kumawat sir, please sir come over here and felicitate Nirmal Surya sir. Can you just bring the bouquet from there? So basically, Dr. Nirmal Surya sir, he is professor and he is a pride for the country. He is working in Mumbai. He is a founder member of neurorehabilitation in India. He is the World Federation of Neurology. He has been president. He is running president of Indian Stroke Association. He is founder for so many societies with such rich academic experience and organizational things. It is really indeed our honor and privilege to be here with him. And of course, we'll be listening to him after lunch. And it is really a matter of great pride. And Dr. Antriksh, can you please join? So, neurologist, and with my teacher in medicine. Thank you very much. So, can we all four of us can have a... Thank you. Thank you. Let's break for tea and then come back.
Let's break for tea and please, students, be sharp on within 10 minutes.
नहीं वो उसमें है रिकॉर्डिंग लाइव को तो ऐसे ही रखना टाइम पास है